session. And hi, Dr. Merinjoy Kaimuru, your rapporteur. Thank you. Over to you, Prof. Mushiri.
Yeah, thank you very much, Dr. Kaimuri. In this session, we have 3 presenters, and I believe those 3 presenters are already here. And like we did yesterday, each presenter is going to be given 15 minutes. You share your results, your research with us, and the audience can hold any of the questions, comments, or suggestions that they may be having until we get to our discussion session. So the key thing is that as you present, know that we're going to time you, and after 10 minutes, we are going to alert you that you've got only 5 minutes. So please organize yourself so that we can have this presentation within the time stipulated. So for now, let me invite Gatobu Kenneth to come forward so that you can start off a presentation in this session. Thank you. In the meantime, those who are going to present, we've got only one computer that we can use to make our presentation. So you may want to give your presentation to the media section so that it can be factored in during for the presentation. Please. Thank you. And to our assistants.
Sioni casa. Sioni casa.
Thank you, Gato. You can take it off.
Thank you, Chair, and our rapporteur, and the audience at large. My name is Kenneth Gitobu. I'm an MSc student in sanitation at Meru University. I'm here to present my seminar paper, which was part of my thesis. And my topic was on methods of pharmaceutical waste management disposal that is being practiced in community pharmacies and households in Kobo Town, that is in Menti South of Meru County. Brief to my introduction. Globally, there are no accepted or there are no standard procedures that are there for pharmaceutical waste management, that is for both households and for community pharmacies. And when we talk about pharmaceutical waste, we are talking about drugs that are expired, those ones that are spilled over, those ones that are withdrawn, those ones could be damaged or contaminated. Those ones are the ones we call waste, pharmaceutical waste. The pharmaceutical waste management now has emerged as a serious challenge issue, both to the health and the environmental, bringing about the negative impacts. The disposals could come as a result of maybe draining the remedies in the sinks and on the drains, and thus they pose a great danger to the animals and to the human health. The general objective was I explored the input of this pharmaceutical waste management, disposal management across the sanitation service chain, that is among the community pharmacies and households. Then narrow it down specific to what I'm presenting today, I determined the common methods of pharmaceutical waste management disposal practices along the sanitation service chain that are being practiced in Kobo Town. We are aware that, to my problem statement, there is an increase in disease incidences and prevalence, and that calls for prescriptions that are coming to and forth from different health practitioners. These prescriptions are either dispensed mainly from our community pharmacies, and where do they end up? They end up to our homesteads. From our homesteads, a good number of our people or our population are not able to consume these drugs. So what happens thereafter? Within a span maybe of even 2 days, maybe you're given a medication of 2 to 3 to 5 days. After 3 days, maybe for several reasons that maybe unpleasant taste, or you get better, you decide that you're no longer taking these drugs. This part of the medications that we are calling, or we are saying they are inappropriately prescribed and consumed by our population. Thus, this possession of these unexpired and unused drugs will of course cause a great danger both to the environment and to our human health. The methodology I applied was, the study area was in Kobo Town, as I said earlier, that's in Menti South of Meru County. The study design was a descriptive cross-sectional design. The total population of that area for the households is 7,675, and for community pharmacies, narrowed it down, calculated this using the proportion to area ratio, came up with my sample size of 3 households and 19 community pharmacies. Data collection too, there are questionnaires both for the household ends and for community managers. This information was also for data analysis and management. I used the SPSS version 22, and my standard findings were presented in figures and tables. The ethical considerations, I got approval from IREC, the number is there. Also from NACOSTI, the number is there. And permission was also sought from the Innate South of County Health Department, and of course a written consent from my respondents. Part of what I was able to gather in the field, I was looking at 2 areas, that is the community pharmacies and the households. For the method of disposal that was mainly practiced in households, of course, most of them tended to dispose their waste in the pit latrines, going down all the way to some draining it on the sinks. The percentages are given there, and the frequency out of my 380 respondents. The same case applies for community pharmacies. Banning was majorly used by those in community pharmacies, narrowing it to the municipal correction, a total of 19 of them. These findings helped me to form part of my discussion. We are aware that this pharmaceutical waste has gained a lot of attention due to the improper and indiscriminate use. Risks that are involved could vary from water, the risk that could go to water, the agricultural products, and in the long run, in the food chain and harm our livestock, and eventual effects on the sanitation value chain. Also of importance to note is those unwanted pharmaceuticals can be disposed of through the sinks and the toilets, and as a result of these unwanted disposals, they will determine the amount of the potential contaminant in the water and other environmental areas. So, as I said earlier, there's really a growing concern because case in point, part of these pharmaceutical waste are the antibiotics or antimicrobials, which interfere with the water treatment processes, because these water treatment processes depend majorly on biodegradation. Then other effects are on untarget organisms like humans, where they cause increase in morbidity and also mortality. To my conclusion, the most common practice that was being practiced, the most common disposal method that was being practiced for households was emptying the pit latrines. Well, for community pharmacies was burning. Then disposal, from a discussion, the disposal of these pharmaceutical products is unsafe and is prevalent among the respondents. And also, part of my conclusion was that community pharmacists are in an excellent position to educate the patients and the general public on pharmaceutical waste disposal methods. My key recommendations, we need to create public awareness and establish educational programs regarding management and handling of unwanted pharmaceutical waste, and then a further national study to investigate the magnitude of pollution with pharmaceutical waste across the sanitation value chain in Kenya. And also of importance is to train the pharmacists and the pharmaceutical technologists who are the focal people who are in the field in handling, dispensing, and eventually who advise patients on rational drug use. Thank you so much, Chair, and for this chance, and I beg to stop there.
Thank you very much, Gitobu, for the wonderful presentation. Please let us appreciate Gitobu for the good presentation that he shared with us. I think we'll move to the next the presentation. Those who may be having questions, comments, and suggestions, please put them down somewhere. We'll have a discussion session after this. So now I call upon David to come and share with us yellow fever virus disease, a systemic review of reemergence, incidence, and mortality in Isiolo County. You have 15 minutes or less because we have a lag behind. Please. this morning. Alfred is around. Please, we'll bring you as the last presenter. Okay? Yeah, this morning. Thank you.
Thank you, Chair.
Oh, no. Yeah, you will not be the last. That's what I'm reminded. Yes.
Thank you, Chair. My name is David Kirongo. I'm going to do a presentation on a systematic review study we did together. I'm a PhD student in epidemiology. We did it together with Victor, Mariam, and the guidance of Professor Magambo. We looked at yellow fever virus in Isiolo County. Mostly we focused on factors motivating its reemergence, incidence, and mortality that occurred in Isiolo earlier in the year. So back straight to the background, yellow fever virus disease is an acute hemorrhagic vector-borne disease caused by arbovirus of the flavivirus genus. It's transmitted mainly by a bite by anthropophilic Aedes aegypti mosquito, and it usually has a high fatality rate. Transmission occurs worldwide in 44 countries, and this puts nearly 1 billion people at risk of infection, according to WHO 2022. Approximately 200,000 infections occur and 30,000 deaths occur every year, with nearly 90% of these cases occurring in Africa. Disease burden is estimated by 2013 to be between 84,000 and 170,000 severe cases. 29,000 and 16,000 deaths were also recorded between 2013 and 2022. But of course, these estimates may not be accurate because of underreporting and misdiagnosis. If you look a bit, you'll find that most of symptoms or presentation of yellow fever disease are similar to malaria. So there's a lot of misdiagnosis which may interfere with accurate presentation of data. In the period between January and June this year, there were a high number of cases of yellow fever virus in Isiolo, and that's what prompted our interest to review and look at what was happening. We had 69 suspected cases with 7 deaths. Case fatality rate was at 10.1%, according to a report from the Isiolo County government. The study, we did an exploratory study following a systematic review approach. We used an approach to review a number of published data in literature, journals, and also the periodicals by WHO. We reviewed a few journals from Medline and Mendley. We used the criteria of looking at studies not back as far as 2019 to 2021, and periodicals for 2022, and the annual reports by WHO concerning yellow fever. We identified predictors of yellow fever world over, and especially in Africa, where the local mosquito Aedes aegypti is the primary cause. We also recognize that eco-climatic conditions, that is climatic changes which we are experiencing with global warming, socio-political conditions, socio-demographic factors, population density and mobility, as well as vaccination coverage, which influence the spread of the infection. You may realize that there's a very low coverage of yellow fever vaccination, which has been given as 7% in Kenya, which is way below the target given by WHO, which is 80% for our population to be able to acquire herd immunity. And that puts the population more at risk for infection by yellow fever. Yellow fever in Isiolo County, just a brief. Prior to the occurrence of yellow fever this year in Isiolo, it had never occurred in that county prior. So it was the first time we're experiencing yellow fever in Isiolo County, and that's why it was of interest to us. As you may realize, Isiolo does not share any international boundaries. It's within, almost at the center of the country. It's our neighboring county. So we were a bit curious to understand how yellow fever could occur in a county that does not share international borders. And we found out a few issues which I'll discuss as I conclude. But one of the key issues is that there's a lot of movement. There was a lot of movement in this period from the neighboring counties, Marsabit, Garissa, and the counties that are around due to the drought that was there. So there was a lot of pastoralist movement with their animals from Isiolo, from other counties to Isiolo, and that is one of the factors that increased the risk of occurrence. The number of cases that were high was mostly in Meti sub-county, Gabatula, and Isiolo sub-county. From the onset of the outbreak, deaths were reported, and as I've said already, our case fatality rate was at 10%. 69% of the cases, 69 cases were reported, 54% were males, that accounted for 79%, and 15 were females, which accounted for 21%. The median age for the number of cases was 23 years, but all the cases ranged from 1 year to 78 years. This is just a histogram representing the distribution of the suspected cases. We put them in epidemic weeks from January through to May. You may realize that there was a spike in a number of cases in week 7 and 8, that is in February, and 9 and 10, that is in March. Mostly because this was a drought period, and Isiolo had experienced a bit of rain, so there was a lot of pasture within Isiolo, and most of the pastoralists from the neighboring county moved into Isiolo, and that is why we had a bit of a spike of the number of cases during those periods from our review. A bit of epidemiology. Yellow fever is well distributed in Africa, mostly in West, Central, and East Africa, with majority of cases and deaths occurring in the sub-Saharan section of Africa. Kenya is endemic for yellow fever and is classified as a high-risk country, and it is listed as listed in the WHO Eliminate Yellow Fever Epidemics Strategy, which runs from 2016 to 2026. There have been previous outbreaks of yellow fever, 1992 all the way to 2016, and the newest outbreak now was in 2022, as recorded by GOK MOH 2022. As I've said earlier on, you realize that failure to implement universal coverage in terms of yellow fever vaccination is a key contributor to outbreaks of yellow fever. Sporadic human yellow fever cases also occur in populations of low immunity due to poor coverage of vaccine for yellow fever. I'll just give a brief of things that we found out as factors that are drivers of the re-emergence of yellow fever. We found out that re-emergence of yellow fever is multifactorial, and it involves hosts and vector susceptibility, vector competence, climatic change, viral genetic variation, fitness, insufficient vaccine coverage, and uncontrolled urbanization, as well as deforestation, which we are really facing in our country. Isiolo has had a lot of human and animal movement. It is next to a national park, and we know that there's transmission of yellow fever from primates to humans through the mosquito bites, and this has also exacerbated the spread of the outbreak in the county. Urban outbreaks, which we've not experienced in Isiolo, but they're usually more deadly than countryside or rural outbreaks because they are disruptive and they are easily transmitted. Presence of overcrowding and populations that are in areas with mosquito reproducing grounds, for example, poor sanitation and poorly controlled environments which encourage growth of female Aedes mosquito causes a higher risk, or it's a factor of reemergence. Our findings from the review, a few is that Kenya has not conducted large-scale preventive mass vaccination for yellow fever. We've had a lot of mass vaccination for polio and other diseases targeted for elimination or emerging diseases, but for polio, we've never had any mass vaccination. Routine yellow fever vaccination coverage is very low among the target population. As we've seen, for the entire country is at 7% and much lower in Isiolo County, I beg your pardon. Majority of the cases were from the 3 sub-counties that are in the area of Isiolo where there was higher rainfall compared to the other areas of Isiolo County. Highest incidence was recorded in March with 21 new cases reported, and as I've said earlier on, this was due to high availability of pasture. So there was an influx of farmers and their animals and a lot of human movement within those areas. In the identified period, there were 7 deaths, case fatality ratio of 10.1%, and the percentages as I've given, a higher percent of cases was in males, and mainly because males are the ones who are moving up and down, and most of them are the ones who stay in the field with their livestock. In conclusion from the review articles, it is evidence that active surveillance and reliable epidemiological data on yellow fever could avoid high incidence rates and unwanted case fatality rates. Accurate data is substantially needed for policy design and also for facilitation of planning for vaccination volumes against yellow fever. Public health strategies, for example, control of breeding sites for mosquitoes is also essential in reducing yellow fever in this region. These are a few of the articles which we considered in our review, and I think with that I come to the end of my presentation. Thank you.
Thank you very much, David. Let us appreciate David for the good presentation. Again, we'll move to the next presentation and keep our questions until we get to discussion session. And that is, we invite Dr. Patrick Kobai to share with us his research on coronavirus epidemic response among health workers in selected health facilities here in Meru County. Patrick. ICT can come forward to load the presentation.
Okay, good morning. Good morning. My name is Dr. Patrick Kinyokubai. I want to share with you the information which I got immediately after the outbreak of COVID-19, that is in 2020. Remember, we were very high dose, so I went to the field and did a baseline survey on what was happening in our sector, that is among the healthcare system workers, a case study of Igembe South, that is in Meru County. As you know, COVID is still a thorn in the flesh in our sector, with a lot of challenges and even with acceptance of the new interventions which are coming in. So the aim of my study was to investigate the level of preparedness and response among healthcare workers in Meru County, and specifically in Igembe South constituency or sub-county. When the outbreak came, there was a lot of uncertainty and a lot of fear among the healthcare workers, despite the fact that they were given the mandate to take care of the people who were affected. So on my introduction, I really also wanted to see what is the genesis of this virus. Coronavirus is a virus which has been studied since 2012 in Asia, with its beginning of what we call SARS and MRS in South Asia in 2012. A lot of literature has come out, but in 2020 in Wuhan city in China, there was the leakage of the virus into the environment, and it caused a global pandemic. What is the magnitude of the virus as of date? As of date, about 539,893,838 COVID cases have been confirmed in the world. That is as of June. The total number of deaths which have been computed to date is indicated there. That is as of June 20th. And a total of around 11 million vaccines plus have been administered. What does that tell you? It tells you still the community and even the people who are supposed to be getting these vaccines are not yet consuming or accepting them as a mode of intervention. So the COVID virus stirred a lot of anxiety among the population, and even to date, it's a challenge. The frontline healthcare workers were not left out in terms of the impact and the effect. So you don't expect the response to be good when the people who are supposed to be giving the response on delivery of these interventions are not at peace, or they are not ready for the work. So what is the history of COVID virus or coronavirus? As I've indicated, various studies by Bakar et al., Shabab et al. Shows that this virus has circulated in over 184 countries, disrespecting all the epidemiological trends of disease transmission. And actually, that is the most unique thing with the COVID virus. It doesn't respect any geographical, environmental factors when it comes to disease spread. So it is a zoonotic pathogen transmitted by animal to human and human to human interactions, and therefore making it very deadly and easily to spread from one person to another. I want to go to my specific objective, broad objective. The broad objective which I had as I was going to the field was to investigate the level of preparedness and the response to coronavirus outbreak among healthcare workers in Meru County. I had 3 objectives: to determine the level of preparedness and response to coronavirus pandemic among healthcare workers, to assess the level of knowledge and response to coronavirus pandemic and healthcare workers in Meru County, and to identify the infrastructural capacity to respond to coronavirus in Meru County. My design was a cross-sectional study design, and this was used to determine the response to coronavirus among the healthcare workers, whereby 87 healthcare workers were recruited and a minimum sample of 77 among the 6 health facilities which were included in the study. The study population was all healthcare professionals, including but not limited to medical officers, nurses, clinicians, midwives, interns, doctors, pharmacists, nutritionists, record officers, and all people who are involved in healthcare system. The inclusion criteria was healthcare workers working within Meru County and who have consented to the study in the last 6 months of study. Exclusion criteria were those not in the area of the study. And this stage cluster sampling design was used to recruit the 87 participants, and every facility selected was considered as a cluster. I used a simple random sampling to allocate the respondents, and a sampling frame was obtained from the e-health, from the Ministry of Health. This is the formula which was used. I will not explain. This was the 3-stage cluster sampling which I adopted to get my 87. So I want to share the results. Ethical approval was gotten from KEMU, ethical committee with that approval number. Healthcare workers were categorized in 2 broad categories based on the level of risk to coronavirus. The first category of healthcare workers were those who are at high risk, and these are specifically people who work in the laboratories, people who work in the wards and all those areas. So the mean range was 34 plus or minus 9 as SD years, with the minimum age of 19 and the maximum age of 70 were recruited to take part in the study. Out of the 87 participants, and the reason why we have 70, there are some people who are working in contract in some of the non-governmental organizations where I interviewed. Out of 87 participants, around 51 and bachelor's degree, 30 and participants had ordinary diploma, while 6% and certificate. Remember, one of the objectives was to check the level of knowledge among the workers. Other professional disciplines included recons and others, other social workers or other allied workers, including social workers. And remember, social workers were very key when it comes to delivery of home-based care. So most of the participants, that is 48 or 55.2%, reviewed that they had worked in the particular facility for a period of 1 to 3 years, with a small proportion indicating that the period of work in their health facility was 7 to 9 years. These are direct dimension on how they delivered the healthcare services and how they could integrate the delivery of home-based care services for the patients who they are coming into contact with. The level of preparedness to COVID-19 was assessed using the Likert scale. Most of the participants disagreed that they had been trained on case definition of COVID-19 or coronavirus infection according to WHO. Majority at 81.6% responded strongly. They strongly disagreed that nurses are more equipped or were more equipped to handle the cases of COVID-19. And actually, if you remember, they were the most casualties when it came to deaths attributed to healthcare workers. Similarly, high proportion, that is at 82.8% of the respondents, strongly disagreed that non-core hospital workers were prepared to, and this is true. And that is why there was a lot of stigma among the healthcare workers, and even to date, it is a challenge. This is a graph indicating the response to coronavirus among the healthcare workers. You can see this is another table also indicating the preparedness and the response among healthcare workers in Meru County who are trained on case definition, nurses who are more equipped, clinical officers, and you can see the percentages of how they responded to the questions. So from the study, it is indicating that healthcare-based indicators or healthcare workers in different facilities are always frightened when an epidemic occurs. Whenever there's an epidemic, there's a lot of fear among healthcare workers, despite the fact that there are people in the front line to take care of the patient. Remember, even our Kenya medical training colleges and even medical schools were closed. So COVID-19 posed a great threat and risk to healthcare workers, attracting a lot of global immense scrutiny, and studies also were done. Sustaining safe and quality healthcare delivery amid SARS pandemic was dependent on health and the mental well-being of healthcare workers. Maybe I go to my recommendations. Sorry for that. Yeah, there's something I wanted to mention. Yes, on the recommendations, the recommendation is that the director of healthcare, the director of public health in Meru County or even at the national level, we require to have effective response to COVID-19 should be a multi-pronged approach, whereby the training institutions have been left out, the stakeholders were left out in training, and that is why maybe the response was not very good, and also the curriculum itself in our country was not prepared, especially when it came to retraining and reorientation of healthcare workers who are involved in the frontline service delivery. It is further recommended that further evaluation be conducted to identify the level of preparedness and the response for future pandemics. Like now we are talking about monkey virus or what's coming up, we should be prepared. Evaluation of COVID-19 effect in management of client or patient by healthcare workers with existing healthcare settings. Remember that the fact that COVID outbreak came or the pandemic came doesn't mean other services like diabetic care, heart diseases, HIV were stopped. So there was need for integration, or there's need for integration and studies to see how we can integrate services whenever there is a challenge. Adoption of the minimum essential package for home-based care for COVID-19 to reduce burden of disease and in our healthcare system. For our healthcare system to survive, we need to be prepared and reduce the burden of disease by having what we call top-down referral of the patient to the community, so that we don't always keep taking patients to the hospital, because hospitals don't have the capacity to do that. I beg to stop there. Time was not very much.
Thank you very much. Thank you very much, Patrick. Thank you very much, Patrick, for the good presentation. Please join me to appreciate Patrick for the good presentation. Please note your comments, suggestions and questions until we get to the discussion session. Thank you, Kobai. Let's move to the next presenter. And the next presenter is going to be Dr. Alfred Mugambi Mariga. Please, we call you upon to come and share with us your research. This man is there too. Nakitari.
Good morning, everybody.
Good morning to you.
Yes, my name is Dr. Alfred Mugambi Mariga, a lecturer in the Department of Food Science, and I'm glad to be here, and I'm glad you're my audience today, and I welcome you to presentation of this work, which is mainly a review on the potential application of mushroom as an anti-aging agent. I have pictures of the mushroom I'm talking about, and normally we have around 150,000 mushrooms, and of these, around half of them are edible. This has been my work, both master's and PhD, and maybe some of us have not interacted with the mushrooms closely. We just eat them and brush up saying they're not our foods. The first one is Agaricus bisporus, which we call button mushroom. The second one is king oyster mushroom, which we call Pleurotus eringi. This is what I've been working on in my PhD, but also these we work closely with my supervisors and professors in China. And these are very good dish, a delicacy from the same mushroom, that is Pleurotus eringi. How do I go next? Yes, and without wasting much time, I'll explain some of the aspects of the presentation, especially what aging is. Aging is a progressive physiological change in an organism that leads to senescence or a decline of biological functions of the organism's ability to adapt to stress. And this can take place in cells, organs, or the total organism as time goes by. That is, you can't stop aging, you have to age. And normally, as much as it's a natural phenomenon, we can stop it or we can slow it by two things. Firstly, we can use what we call enzymatic and non-enzymatic antioxidant mechanisms. Normally, oxidation or aging is brought about by reactive species, which is brought again up by two things in our lives. And firstly, we have the exogenous factors. And once you talk of exogenous factors, you're talking about the pollution, you're talking about the foods that we eat, we are talking about smoking, we are talking about the drugs, we are talking about excessive alcohol drinking. And when we talk of endogenous, we are talking about our innate system. That is, we have enzymes in our system, which are redox enzymes, that is reduction oxidation enzymes. We have things like xanthine oxidase, we have things like lipooxygenases, we have enzymes like glucosidases. And as a result of all this, what happens? We've said that causes of the reactive species are both environmental and endogenous. This will produce the free radicals that we've just discussed, that is the reactive species. And for reactive species, we've seen we have reactive oxygen species, we have reactive sulfur species, and we have reactive nitrogen species. Now, once these radicals are produced, they have their target. Where do they act upon? They act upon membrane lipids. We normally know in our cell we have a protein layer sandwiched between two lipid layers. So they attack the middle layer, which will interfere with the integrity of that cell. They act on proteins, nucleic acid. We know once the integrity of a nucleic acid is affected, mutation can occur. And this is how cancer happens. Also affects carbohydrates. And the end result is cancer, cardiovascular diseases, neurological disorders, which include Alzheimer's. We have pulmonary diseases, diabetes. We have atherosclerosis, meaning hypertension, strokes, among many others. Now that we've said that aging is inevitable, or our systems produce antioxidants, how do we cope with that? Our system, or our bodies, have what we call innate antioxidant defense mechanisms. And I think I mentioned them, whereby we have enzymatic, and these, we'll see them as we proceed. But to a large extent, this natural defense mechanism is not enough. So what do? We supplement it or we boost it. And we do this by consuming foods which are high in antioxidants. And these foods include our normal day-to-day foods. And currently, I know with the change of lifestyle, we've modernized so much that we want a convenient food, a food which will fix so fast and eat. But most of these foods are sources of oxidant, free radicals, as we've seen earlier. And for example, I'm a food scientist, but as much as I advocate processing, I'm also a nutritionist where I advocate people eating whole foods. For example, we have things like crisps in the supermarkets. These are what we call highly processed foods. And they have things we call trans fatty acids. These lead to oxidation of polyunsaturated fatty acids in our system, leading to production of free radicals as we've seen earlier. So to curb this, we use foods high in antioxidants, and these foods include plant-based foods and fungus. Why fungus? Most research currently, and even many years ago, has embraced the importance of fungi in our system, in our day-to-day life. For example, the leading antibiotics, the multi-billion-dollar industry of penicillin, come from mushroom, and many more medicinal or bioactive molecules. So, mushrooms are the perfect candidate for this. And as you can see, I have a very good picture of, I don't know whether it's clear to everybody, but there's a mushroom which is growing on a head of a caterpillar of a certain insect, which is normally found in the high altitudes of China. And this mushroom, we call it Cordyceps Sinensis, which is an endoparasitic fungus. That is, it grows on living organism like that caterpillar. It grows on its head. And this mushroom has been researched so much, leading to production of an anti-aging drug which is very expensive and not very common. We call Aerovit. So as much as mushrooms are concerned with antioxidant activity, which is synonymous to anti-aging, we need to isolate, or we need to know which molecules are responsible for this. And we do this by isolation, purification, identification, and then characterization. Problem statements. As earlier stated, with the advancement of technology currently, there has been tremendous change in terms of lifestyle, infrastructure, which has led to change of the way we do things, and also has brought new pollutants in the environment. And this subsequently lead to premature death due to aging, and aging, we've seen the causes of aging is a reactive species, which lead to very many diseases like cancer. And for example, if we all are current with what's happening currently, is that Meru is among the leading counties whereby cancer has been rated highly. And if you go to Meru level 5, you can attest to that. Thank you. So the objective of the study was to identify the main active compounds in mushroom, edible mushroom. Secondly, was to determine bioactive compounds that have antioxidant activity in these mushrooms. And lastly, I wanted to discuss the mode of action. Sorry, there is so much data on the same, and as you can see, there are a lot of studies which have been done on mushroom. And with this, we've come up with so many bioactive compounds which can lead to anti-aging activities. And some of them, when you talk about non-enzymatic systems of antioxidant defenses, we have vitamin C, which we call ascorbic acid. We have tocopherol, we have carotenoids, polyphenols, uric acid, and trace elements. And for enzymatic, we have catalase, we have superoxide dismutase, and we have glutathione peroxidases. Now, I went through quite a number of works, mine included, and I came across so many antioxidants, so many bioactive compounds, and of this, I identified the compounds which were responsible for antioxidation, and these include phenolics, tocopherols, ascorbic acid, beta-carotene, and trace metals. Normally, polyphenols exert their activity by chelating. Chelating means quenching or trapping the free radicals. They can also stimulate the endogenous antioxidant molecules in cell via nuclear reactive factor 2 or antioxidant responsive element pathway. We have polysaccharides, which have also been recognized as major antioxidants in mushroom. And what they do is that they scavenge. Most of them, they scavenge for free radicals. And we know the first respondent to oxidation in our system is the red blood cells, which might be oxidized and consequently become hemolyzed. And so the mushroom polysaccharides act as antioxidant by taking process in the activity of the enzymes that I've discussed. That is superoxide dismutase, catalase, and glutathione peroxidase. Vitamin E, we all know that in all fat-based plant and animal products, vitamin E is part of it. That is, during creation, God thought that it's important to put an antioxidant in our systems. And vitamin E is one of them. Normally, the equation shows when we have long-chain polyunsaturated fatty acids, the double bonds leads to free attack by the free radicals that we've talked about. So what happens is that when these are attacked, they produce what we call peroxyl radicals, and these peroxyl radicals will then act on the membranes that we talked about earlier. So how does vitamin E or tocopherol arrest this? It reacts to the peroxyl radical, and then because of its double bonds, it's preferentially oxidized, leading to a stable a stable tocopherol radical, and also a stable adjunct. As you can see, LOOH, that's very stable and does not affect our system. Vitamin C, again, it's very important because it's like rejuvenates vitamin E. After vitamin E has been used and converted to a reactive vitamin E, it's again converted back to an antioxidant vitamin E. Carotenoids are found in every vegetable. For example, when you talk of green vegetables, they are green because the carotenoid, which is yellow, has been masked by the green color. And normally they act by also being preferentially oxidized because they have long chain and so many double bonds. So when they interact with the peroxyl radical, they are oxidized instead of our biological membranes. Conclusions and recommendation. This is just a tip of the iceberg. With the time and the number of slides I've just brushed through, as you've witnessed, but there is immense work on the antioxidant activity of mushroom. And earlier I had discussed, not in this conference, the anti-cancer activity, and now is antioxidant activity, which is synonymous to anti-aging. So we see that mushrooms have immense activity in terms of our health, but we don't consume them. There are very few people who have consumed any mushroom in their lifetime. Me included. I consumed my first mushroom in China, and China is their normal delicacy. But on coming back, I don't remember the time I came back in 2014. Until today, I've never consumed a mushroom. So I think I should preach water and drink water. I should start by myself. But my recommendation is that we should promote production, collection. There are communities that collect mushrooms from the wild, like the Kisi people, and hence promote consumption of these noble and very important products. Thank you.
Thank you very much, Dr. for the good presentation that you've given us. Let us appreciate Dr. for the beautiful and wonderful presentation that he's done. Now, already, since we came back for this session, we've already done 4 presentations, and I think we can take one more so that we can get to the discussion session. So I don't know whether you are ready. Faustina, please, you can step forward so that you can share with us your presentation. Shitemi is going to share with us an assessment of knowledge, attitude, and practices of healthcare waste management among nurses in Nyambene Level 4 Hospital.
Good afternoon. Okay, I'm Faustina Shitemi, a former nursing student who graduated in the last graduation. So we did a research on assessment of knowledge, attitude, and practice of healthcare waste management among nurses in Nyambene Level 4 Hospital. And we did it together with Momanyi Pius Nyabaro, Keter Moses, who are here today, and our supervisor was Dr. Mary Joy Kaimuri. So first of all, as you know, we are nurses, and during our clinical rotation in various hospitals around here in Meru, we came across a major challenge in those hospitals, which was healthcare waste management. And so with that, we decided to do a research on what was the main problem there. So, and what is this healthcare waste? Healthcare waste is a waste that is produced in various, when doing procedures in hospital like surgery, delivery, autopsy, and also injection. And these healthcare waste, most of them, they are hazardous. And when we mean hazardous, it means it can transmit various infections from one person to another. And majority of people who are at risk of this infection are the healthcare providers. So, and when we don't manage this healthcare waste properly, we can risk a lot of population. That's why we wanted to know what is this problem that is there in the hospital, and to come up with the solution that can be put in place. So the problem, we decided to choose a hospital around here in Meru, which was Nyambene Level 4 Hospital, and we chose that hospital because it was convenient for us to do that research there. And when we went there, the main problem that we found there was, you know, in the hospital, we have to have different color-coded bins so that we can separate this waste. We have different types of waste. Highly infectious, and non-infectious, and also we have the sharps. So we are supposed to have different color-coded bins so that we place this waste in various bins. So in Nyambene Level 4 Hospital, the main problem was that, yes, there was this color-coded bin, but segregation, that is separating the non-infectious, infectious, and highly infectious to different bins, was not being practiced. So, and when we compared with another studies that had been done in collaboration with you, it was found that the medical waste management practices in most health facilities did not meet the international set standard. So our main objective was we wanted to assess what are the knowledge of the nurses regarding the healthcare waste management in Nyambene Level 4 Hospital. What is their attitude? How do they feel about healthcare waste management? And what is the nurses' practice? How are they doing this healthcare waste management? Those are the three main objectives. So the method that we used, we carried our research in Nyambene Level 4 Hospital, and we divided nurses in different departments, NBU, maternity, and all those departments that were there. And we used questionnaire. We gave the nurses the questionnaire according to the departments. And the study design that we used was descriptive cross-sectional design. And because the nurses were few in Nyambene Level 4, so we decided to include all the nurses. The nurses were 61 in numbers, but we divided them according to the departments. So we go to our findings. So as we said, we had 3 objectives. So we wanted to know their knowledge, practice, and attitude. So we started with the knowledge. What are the knowledge of the nurses there in Nyambene Level 4 Hospital? And in general, we realized that they had a good knowledge. And with that, as you can see in the graph, a majority of them had a good knowledge in healthcare waste management. And that was 57 of nurses had good knowledge, and 4 had average knowledge. So we categorize knowledge as either good, average, or poor. So in short, we didn't find nurses who had poor knowledge. And because, as I mentioned earlier, we gave out the questionnaire, and our questionnaire had a total marks of 30. So a nurse who scored between 10 to below 10 had a poor knowledge. And then 10 to 20 had an average knowledge, and above 20 had a good knowledge. That's why that's how we came up with these who had good knowledge and average knowledge. So in total, the percentage, as you can see there, 93.4% of nurses had good knowledge. And as I had mentioned earlier, we had some component that we wanted to assess in this knowledge so that we can determine their knowledge. And here we had some few things that supported that these nurses had good knowledge. As you can mention here is that 100% of nurses stated that waste are disposed in color-coded bins. Yeah, they knew that these waste should be disposed in various color-coded bins. So it shows that they know what is supposed to be done. And another one was that they also mentioned 98.4 that they have been trained on waste management. And also they know the principles of waste management. These principles are disposing the waste in various color-coded bins. And then we go to the attitude. In our questionnaire, we use a Likert scale to determine either the nurses had positive attitude or negative attitude. And in overall, we notice that these nurses, 52% had a positive attitude, while 47.5 had a negative attitude. And in supporting of that, to show that they had a positive attitude, there are some few elements that we assessed to determine their attitude. And here we saw that 90.2 of the nurses strongly agree that improper waste management is a threat to the hospital population. So when you analyze that question, you see that they know their attitude or their feeling is that it is a threat to the hospital population. And also 54.1 strongly agree that waste management is everybody responsibility, the whole population, either doctors, clinical officer, it is everybody responsibility. And though in attitude, there are some few things that shows that some nurses had a poor attitude. Like in that element there, 85.2 strongly disagree with correcting colleagues when they don't adhere to color coding protocol. In short here, when a nurse sees another person disposing a waste to the wrong bin, that nurse maybe say it's not the responsibility to correct the other one. So that's a poor attitude. And also 73.8 strongly disagree with reminding colleagues of proper waste management. So those are some few attributes or components that shows the positive attitude and also the negative attitude. Now we go to the practice. This is a major thing that we noticed as I had mentioned earlier, which was the problem. So the study finding shows that 55.7 of the nurses had poor waste management practice, while 36.2 had good practice. As you can see that the percentage of poor waste practice is high, and those with good practice is low. Good practice is 36. Sorry, we had good practice, poor and average. That's an error there, sorry for that. So 55.7 had a poor practice, 36 is an average, and then we have 8.2 had poor practice. So, and there are The finding now in poor practice, the evidence in some elements that we assessed using our questionnaire, we saw that some nurses state that they did not dispose of the leftover in trash bins. In short, they are doing what is not supposed to be done. And also nurses state that they do not always ensure availability of 3 color-coded bins. Sometimes when you go to those hospitals, those color-coded bins, they are not all of them. Sometimes you only find 2, and they supposed also always to be 3 together with a sharp container. And also labeling, you are supposed to label rightly, like highly infectious, non-infectious, and infectious waste. So sometimes it is not labeled well. When you don't label well, so it increases the mixing of those wastes. So, however, 82% of the nurses indicated that they always ensure the bins are labeled. So those are nurses that which indicate good practice in waste management. So in general, our finding shows that nurses had good knowledge, and we compared with another study that had been conducted, Kumari 2020, which also concluded that 90% of the nurses had excellent knowledge on waste management and its complication. And also in attitude, generally we saw that nurses had positive attitude. And when we compare to another study that had been done in 2016 by Mohesen, it established that 85.5% of nurses expressed their willingness to cooperate with the hospital management regarding the healthcare management. So this study also showed that the majority of nurses had poor waste management practice. And when you compared with another study that was conducted in 2019 by Vanesh, which established that a good practice on waste segregation according to color-coded bins. So in conclusion, generally nurses had good knowledge, they had a positive attitude on prioritizing waste disposal, and the main problem was they had a poor waste practice management. And what was the main things that contributed to these poor waste practices? We tried to analyze using the components that we had assessed. There were no set guidelines that used to guide the nurses on waste management. Also, there was ignorance from nurses, and also some nurses were not willing to train the junior nurses, those who like for student nurses who go there for clinical rotations. So those are some things that contributed to these poor waste management practices among nurses. So we came up with a recommendation that will help us to solve those problems, and these are some few recommendations that we came up. We saw that when we introduce our program to emphasize on proper waste management practices, like in an hospital we have a certain program that will guide the nurses on waste care management. It will help to solve that problem of practice, poor waste management practice. And also we have something called CME in health. This is a continuous training of nurses or also medical team on emerging issues. So we told that continuous medical education regarding this waste management among nurses, it will try to solve this problem, because like you are reminding them of what is supposed to be done. And those who maybe they don't know what should be done, through this continuous medical education, they're able to know what are supposed to be done. And also written healthcare management plans and policies to be included. So hospital policy regarding this healthcare waste management, and this policy should be available everywhere in each department, and even also if possible to be hanged in the wall, so that nurses can be able to know, and when they are free to go through them. And also the administration to undertake regular inspection and review. So the hospital to come up with a team that is responsible for waste management, and frequently to go to various departments and also to see what is going there so that they can correct if there is a challenge there. And also there is another one, to reward nurses who do what is right. Or for example, we say the department. Sometimes there is a department which usually is doing the right thing. So to reward the nurses there so that it can challenge the other one. And those are some of the references that we use while we are doing our research. Yeah, and I beg to stop there. Thank you.
Thank you very much, Faustina, for the good presentation that you've given us. Let us appreciate the team and Faustina. Okay, now we've listened to 6 presentations. And in view of the time that we've got, I think it would be good for us to have a discussion session before we can listen to our online guest speakers, and from 1 o'clock up to 1:45. So out of the 6 presentations, let us discuss them, let us look at them and see what kind of comments and suggestions that we can give. And I would want to request the presenters to come forward so that if there are any questions, comments and suggestions, you can be able to react to them. Please come forward. We had methods of disposing pharmaceutical waste by Vitobo. Then we had the second presentation of yellow fever in Isiolo by David Kirongo. Then we went to Patrick Kobai, presentation of COVID healthcare knowledge about COVID and preparedness. Then we listened to the benefits of mushrooms as an anti-aging food. So we will have 1 or 2 comments or questions to the presenters. And finally, the last presentation that we've listened to by Faustina. Now, I invite the audience to give the presenters their reaction, excuse me, to various presentations. Good. One thing which I noticed and which is was very clear, that these were very good presentation, and the speakers really did very well. And they brought things that are common to us, but we tend to ignore them sometimes. I'll start with the methods of disposing pharmaceutical waste. You indicated to us that there are different ways of disposing these waste. And you said that out of this indiscriminate way of disposing, a few organisms are targeted. They are targeted organisms. Now, in view of what is happening in our health facilities, are there some diseases or conditions that you may have observed as a result of closeness to where these pharmaceutical wastes are frequently disposed? And what would you advise health facilities? Somebody else can ask something else or comment? Okay, I also have an issue or a clarification with yellow fever team. Yellow fever, you said that this was the first time to be documented in Isiolo. And it was in some remote area of Isiolo. And it lied outside what would be expected to be a yellow fever belt. And that is true. But we have areas which have got yellow fever in our country, like Baringo area. Now, do we have any threshold of the number of the cases, or what would be the World Health Organization threshold of cases for yellow fever? And what did you find in Isiolo? Yes.
Okay, thank you, Prof. For Kenneth, probably it would have been important for you to indicate or to inform the audience, because we are mixed, on the proper methods of how should we dispose the expired drugs and the unused drugs in our homes, and also for the community pharmacies. For the mushroom, I bet most of us do not know the benefits of that you have highlighted, and probably in your recommendation, have you considered public education and awareness? Because I know most of our communities, I think consuming mushrooms is a taboo. So probably educating people, because I know people are now becoming health conscious and they are looking for alternatives of highly nutritious foods. For Dr. Kubai, I probably didn't get well what the level of knowledge was amongst your study population and what you found out about the infrastructure, as it was one of your objectives. For the yellow fever team, when you're doing the review, did you consider that in Kenya we only have certain counties that are mandated to give yellow fever vaccination during the routine vaccination during childhood, and we also do the yellow fever vaccination for people who are traveling out. But I don't think in Isiolo and the northern counties, it's not, the yellow fever vaccination is not mandatory. And then for the healthcare waste team, probably you'd have elaborated more again in the recommendation on the specific issues that need to be included in the policies that should be posted to the ones. Thank you.
Good afternoon. My question goes to Dr. Mogambi. Yes, on the mushrooms. Have always believed that an anti-aging the component is called retinoids. So like on the mushrooms, do they have retinoids? Because you find the retinoids in skincare products, like those ones which are used in sunburns, in everything, in everything concerning aging. Yes, thank you.
Good afternoon. Yeah, I'm Jared. My question also goes to Dr. Mugambi. The mushrooms which you showed on the screen, are they distributed in our country? Because where I come from, we consume mushrooms but whatever you showed is not what I know we eat from where I come from. The next question goes to Faustina. You said that a number of nurses have poor knowledge, and as far as I'm concerned, as a medic, we go through a course which all the medics are educated on the waste management. So how do you respond to that? Thank you.
Yes, okay, go ahead, madam.
Hello, I'm Jemima. My question goes to Dr. Mugambi about the anti-aging. The reactive oxygen species, can the mushroom be consumed by everybody, or there are people who can have allergies or poisoning? And my second question goes to Faustina. It's clear that from the study they did, the nurses had the knowledge, they had the attitude, but still the practices were not being implemented. So I would like you to pin down the main problem of the facility. Thank you.
Good. I suggest we've already had more than 6 questions before you can, before you can give them. Let us give the presenters a chance, okay, so that they can be able to react to some of those questions. I'll start with Dr. Yes, go ahead. You've got at least 4 questions. Oh, good. Yes.
Yes, thank you so much. And I'm happy, because as a lecturer, if you teach and there are no questions on what you've taught, there are 2 things that have happened. Either your students have understood nothing, or they have understood everything. Thank you, Prof. Yes, and for my class, have understood and others have and need clarity. So thank you very much. The first question was asked by Daktari about public education and awareness. These I've not ventured into that. What I do is present, like I've presented now in conferences. I've presented about mushrooms in more than, I think, 5 conferences. And that's one way of reaching the community. And where I come from, we also don't consume mushroom, but I advocate. Once we have gatherings, gatherings will never cease in our community if you are a social animal. So I keep on advocating for that. And with that, I've been asked questions on how to cultivate them, the substrates, how to go about it. And I remember the other day, I talked to various experts in mushroom farming, and we decided, because we have MOUs with very many institutions around, to see a way on how we can get to the community, to make them aware that what they regard as a taboo can be really helpful in terms of their health. There was a question on retinoids. As I said, this was just but a brush through. Retinoids, we know they're a class of vitamin A substances, and as in my presentation, I showed various vitamins, C, E, A. These are part of anti-aging agents which are found in mushrooms. And yes, it's true, many cosmetics or beauty industry, which we know is very multi-billion-dollar industry, they incorporate some of these in them. And that's why we come with we have what we call sunproof factor. For example, people who live in tropics, they need to use those cosmetics which can mask them from the intense radiations of the sun. And that's why they need to know about sunproof factor. You need to use a cosmetic with the higher sunproof factor to prevent you. But we black people have no problem with the sun. We have melanin, so God knew to put us here. That melanin would protect us from the adverse effects of the radiation from the sun. Distribution in the country, I was asked a very good question about the types of mushroom that I showed that they're not within our country or where my friend comes from. Normally, I stated that there are communities that cultivate wild or collect mushroom from the wild, and these mushrooms, you remember I showed a lot of research work, but I could not display everything there. So even the mushroom that you're talking about, I'm sure, has been researched on, and is also part of the research that I presented and has the effects. And that's why we've been thinking of coming up with a research project on the mushrooms that are cultivated wild. Because as you've seen, most of the work is from outside. So we need to do our own work. And I remember we had a project with the Chuka University on the same, but it's still ongoing, about wild mushrooms, to characterize them and see their antioxidants, anti-cancer, all those activities. And it's good that you educate people like us. You tell us you eat mushrooms and encourage us to consume mushroom. Thank you so much. And then about allergies, I've been asked about allergies in mushroom. Normally, it's very important that you don't consume any mushroom. Some mushrooms have what we call hallucinogens. You eat it, you go as higher than a kite. Unakuwa high. And sometimes you start seeing, you start hallucinating, seeing things that are not there. Yeah? So it's important that before you consume a mushroom, you just need to know whether it's safe consumption. We know various foods have proteins which some people are hypersensitive to, like groundnuts have proteins which people react to, but mushroom have not yet so far come to any protein which is reactive to the consumers. And I think with that I've covered my questions.
Yeah.
You had a question, Prof?
Second round is coming.
Okay.
Yeah. Okay, we move to David. David, we had, I think you had 3 questions. 2. Yeah, please react to them.
Thank you, Professor Mshiri. Thank you, Doc, for the questions. You'd asked about notifiable, whether yellow fever, what's the threshold for being notifiable? According to WHO, yellow fever is an internationally notifiable disease. 1 case is sufficient for notification. So if we have only 1 case, especially in this case where Isiolo is outside the yellow fever belt, it meets the threshold for notification. Reason given is because of its high fatality rate and because it takes a bit of time before the microorganism is isolated and identified. So notification by 1 case is given by WHO. The second question asked by Dr. is if during our review we considered the belts that are identified for compulsory vaccination or preferential vaccination against yellow fever. Yes, we did. And Isiolo being outside that belt, vaccination has not been given as mandatory. But we are, according to the Eliminate Yellow Fever roadmap given by WHO 2017 to 2026, they're actually advocating for a more radical approach where yellow fever vaccination is to be included in the normal vaccination schedule so that everyone gets vaccinated for yellow fever. So that is the more approach that we will be moving towards if the approach is adopted by the governments in East Africa and also in Africa at large. Thank you.
Thank you, David. We move to Getobo, so that you can respond to the comments and questions.
Thank you, Chair. I think I have 2 questions. First, I would like to respond to your question, Chair, was on which are the target and the non-target organisms as a result of these pharmaceutical waste disposals. First, Chair, my research was basically, I was looking in health facilities, that's what you asked. The facilities that I was looking at or that I majored in were the community pharmacies and the households. And this pharmaceutical waste will eventually end up along the sanitation chain, will end up being indiscriminately disposed. Once they are disposed, there is no target organism. Of course, it's an untarget organism, but they end up to an untarget organism. But once indiscriminately now disposed, now the animals plus the human beings become the target organisms, which is a negative impact through maybe, once they are disposed, maybe through compost pit and so on, they will end up as manure, end up on our crops, and then maybe you are consuming the same. And this brings about even the antimicrobial resistance that we were talking about. Second, from Mary Joy, Dr. Mary Joy asked about the programs that are being advocated for pharmaceutical disposal. Basically, for community pharmacies, what they are doing, they are being advised, once they have expired drugs or unused drugs from their facilities, they are advised always to quarantine them. Then we have some take-back programs that are being organized by the regulatory body, that is the Pharmacy and Poisons Board, that comes around and picks those drugs. And majorly for households, I would write as part of my recommendation, because these things are not in place, we always encourage them to return back to the outlets, which they don't do. That's why we are looking at the methods that we are doing. And once they return, the recommended ones, among many, we do the incineration. The incineration is done in our major hospitals, where we have the incinerators, like in our Meru County, from Nyambene, I think in Level 5, and I think in Innate South, there is also Kanyakina that can be done. Then there can also be burning, maybe of the boxes that contain the drugs. And lastly, also burning is a recommended method also. Thank you, Dr.
Okay, thank you, Dr. Mary Joy. I had 3 questions. One was from Dr. Mary Joy. The specific policies that should be put in place in the wards. And one of the policies that are supposed to be put in there in Nyambene, the hospital should ensure the color-coded bins are always available and well-labeled so that it can avoid mixing of these waste, non-infectious, infectious, and highly infectious. And also, the nurses should be trained on segregating the waste at the point of generation. So the policy there should be, segregation should be done at the point of generation, and in that, the waste should be disposed at the correct bins. And also, these bins should be disposed when they are 3/4 full. And another question was from you, and I didn't get well. You asked, you said poor knowledge, or?
From your results, I saw a result from those who responded that they had poor knowledge on waste management.
From our result, majority of nurses had good knowledge, 93.4. They had good knowledge on waste management. So the few that we get, I think, the junior nurses.
But why can't we say it is the attitude?
We had the result for attitude and knowledge. So for knowledge, it was good.
So for me, I feel we have poor attitude towards management, but they have the knowledge.
Poor attitude, but the results, as you can see on our results, the knowledge and attitude, it was like somehow balanced, poor and negative and positive, but the knowledge was good. So I don't know, I don't get your question that.
My take can be,
yeah.
This one which are, say poor, is the attitude they have, not the knowledge. They don't lack knowledge, it's the attitude.
Okay, yes. Thank you for that. Okay, and then another one was the question from, it was practice was the main problem. So how should we come up with solution? Is that right? The question that you asked. what was the problem? Okay, some of the problems that we came across is the healthcare teams did not do frequent inspection to various departments to see if these wastes are being well segregated. Another one, there were no frequent, like monthly CME about this waste segregation. Another one was ignorance from nurses. Nurses know what they're supposed to do, but because they don't want to do it, they just ignore. And also there was, as I had mentioned earlier, there are these junior nurses. They don't know exactly what they're supposed to do. So the senior nurses, they are no willing to train them on segregation. And I think that was the question. Thank you.
Thank you very much for the question. Quickly, Kubai, respond to the questions.
Thank you very much.
In 2 minutes.
Dr. Mary Joy. This research was done in a period just after the outbreak of corona. And the result which we got was that there was inadequate knowledge among healthcare workers on the different standards and guidelines for prevention and the mitigation of COVID-19. And having said that, around 65 articles were reviewed just before 30th January of 2020 to check the levels of preparedness for the pandemic in various countries across the globe. And this result actually concurred with that. The other question was the infrastructural capacity. You're asking what were the result. The result was that our infrastructure was inadequate. That is from the result which we got. And that is why in one of my recommendations I've just indicated that now that there has been a lot of teaching, a lot of support in terms of resources, we can do a further evaluation study to see whether the COVID-19 mitigation and the strategies have been taken to that level. In case of the second wave or in case of any other pandemic, we can get to know whether we are prepared or not. Thank you.
Thank you very much, Dr. for the good responses. Again, let us appreciate all the presenters for responding to our comments, suggestions, and questions, and giving us a good presentation. In the next 1 or 2 minutes, we're supposed to be having an online presentation from USA, University of Michigan. That's why we want to ask those who may be having further questions to hold them until next session. So I'm told this presentation is going to be streamed directly from that place to our screen here. Good. So please, I urge you not to leave. Let us wait and listen to this guest speaker, Professor David Crow, who is from University of Michigan, USA. And then after that, we will have also another online guest speaker, Professor Emeritus Dalhousie, University of Canada, Professor Robert Bartolucci. So please bear with us. We will take a little bit of your time, but these presentations are going to be over by 1:45. Thank you.
presentations that we've just earned, we can continue with those. Not necessarily a question, even more discussions. Yeah, Carol has a question. Or we can discuss mushrooms more.
Yes, thank you. This is Sue, Dr. Mariga. This conversation on mushrooms is quite interesting, and I wanted to know about the mushrooms, how far you've gone with your study. Did you say that you have isolated some of the bioactive compounds? And maybe if so, is mushroom, like from your presentation, is it like a superfood with these multiple bioactive compounds? Or does it have some specific ones that maybe are found in other foods, but in case we are not able to access the mushrooms, or we are not able to farm them or accessible, then maybe you can have an alternative? Or we'd really be looking into empowering communities to diversify their diets in mushroom farming? That was my question. Yes, and the other one was to Gitogu. Yes, I was waiting for what next. You talked about the disposal, majorly in the community. It was through the drains and through the toilets, and then to the community pharmacies is banning. And so I was waiting for what next after that. Are you looking into more research into it? Maybe more postgraduate into that, or more research into that, to find out then these non-target organisms that will get affected by the burning in the pharmaceuticals, and also the non-target organisms as we drink the water, as we inhale the air that is contaminated by this. Thank you.
Thank you so much, Carol. And again, I'm intrigued because I told you if more questions come, it means I taught well. And that's thank you and encouraging. And yes, okay, what I did in my PhD was to isolate, purify, characterize, and check the immunomodulation activity, antioxidants, and anti-cancer activity of the king oyster mushroom that I showed there. So I isolated a bioactive protein, which was part of a major research. After I isolated the protein and showed that it could do all that, I left that part to go to the next student, PhD student, who was again to check the mechanism. How is it possible to do that? So it's an ongoing research, and yes, we've isolated it. Apart from that, in my lab, the one I was working in, so many bioactive compounds had been isolated, polysaccharides, and even polysaccharide protein complexes. We had things from various mushrooms. So yes, it's something that has been done. And with that, it's only that I didn't flip to the last slide. Even most of the activity, most of the references that I've referenced there are from my lab and me. Like currently I have over 40 publications in Elsevier on the mushroom. So it's something that I'm passionate about. And whether mushroom is a superfood or whether we can get these components in other foods, yes, we can get these components from other foods, but only that these components are limited. And you should remember that mushroom is a fungi, meaning it's a microorganism. So if you consume a small amount of that mushroom, it will give you more health benefits than if you consumed a vegetable like, let's say sukuma wiki. Remember I said that carotenoid or carotenes are part of the activity of these mushrooms. So If, for example, I consume a mushroom and someone consumes green leafy vegetable or a pumpkin, the benefits I get are higher as compared. Why? It's a single cell, and the absorption rate will be higher than the other one. Remember, plant-based foods, they have nutrients, but their availability is limited because of interactions, either fiber, anti-nutrients like trypsin, and also phytates. So, in that perspective, yes, we can say that mushroom is a superfood. And the good thing with the mushroom is that we have mushrooms adapted to almost every ecological condition. So we can advocate for farming. My friend here, they collect. So what we do, what I think need to be done is to sensitize the community about the health benefits. It's unfortunate, like in a country like ours, we deliver so much, we get so much results from our data, but then insemination and assimilation is really wanting. So I think we can do better, and these are a step in the right direction by presenting our findings, and I think I'll strive to do better in terms of sensitizing our community. And most of these mushrooms that we're talking about.
Sorry, I want to stop him because the other speaker is on, and then we can continue with the discussion after.
Okay, thank you.
I know you can talk back kesho. Thank you so much, Dr. Mariga. We are privileged to have Professor Robert Lossey, who is a Professor Emeritus from House University in Canada. He is joining us online, and I'm told he is already on. So we'll give him a chance to speak to us about sustainable development and innovation. Thank you. Welcome.
Good afternoon. Pleased to be with you, and I look forward to joining you sometime in the future. I may have, it's early morning here in Canada, and I may have joined you earlier than expected. I don't want to disrupt the ongoing program, so if I'm out of sequence now, please carry on with what you were doing, and I'll be ready to start on the half hour if you like.
Professor Robert, we are ready for you, so kindly you can continue.
Oh, okay. Can you hear me okay? Can you hear me?
Yes, you are loud and clear.
Okay, good. And I will try to, I can share screen. I could. Okay. I don't seem to be able to put my PowerPoint up for you. I'm going to do some, oh, here it is. I think this is it. Okay, resetting. Okay. Does the screen show the PowerPoint?
Yes, we can see it clearly, Prof. You can proceed.
Okay, thank you very much. This is the title of the presentation is Micro Research Towards Sustainable Health Research during uncertain times. And I'm presenting it on behalf of my colleagues and co-founders of microresearch, Jerome Kabakayenga, who's from Uganda, and Noam MacDonald, who's a colleague of mine here in Halifax in Canada. So I bring you greetings. Halifax is about 10,000 kilometers away from Kenya by direct flight. We're a seaport city on the east coast of Canada. There's a picture of there, and I'm coming to you from my home university, which is Dalhousie University, and I work out of a building, a hospital, which is part of Dalhousie University called the IWK Health Center. And just to orientate you, Nova Scotia, where I'm from, and Canada by and large, was originally inhabited by what we call First Nations peoples. And this is to acknowledge that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. We're committed to addressing the Truth and Reconciliation Commission's recommendations, and we recognize we're all treaty people. So here are the objectives that I have for this and set out. I hope by the end of this you'll feel comfortable and I will have addressed these five points. Does research make a difference to a country? Does research make a difference for a healthy population? What challenges to doing health are there to doing health research? Pathways to decolonization, and microresearch as an example for sustainable health research. The first question, does it make sense for a country to be engaged in research? And I think most of the people in the audience, I think, would agree that yes, it is a responsibility of a country to engage in research. And this is a graph which shows by country. On the vertical axis is the GERD, or the gross expenditures for research and development per person in a country. And along the horizontal axis is the GDP per person of the country. And you see there's a relationship there. The United States is towards the right, and I did a little circle around the Netherlands. The Netherlands is a country that is the most densely populated country in the world. It has virtually no natural resources other than the natural resource which they've created on their own, which is agriculture. And yet, it is one of the wealthiest per capita countries in the world. And the reason I would argue on that is that a good percentage of their GDP is dedicated to doing research and development, to implementing research findings and the like. And this is something that I think most countries can strive to do. So, if it's a good decision for a country to be engaged in research, is it a good decision for a country to be engaged in health research and health implementation, research implementation? This is a study that was done a few years ago, about 9 years ago, by a person named Kuhn. And what he did was he looked and tried to analyze on a qualitative methodology basis how decisions are made by key decision makers in a country. these decision makers. This might be the Minister of Health in Kenya. It might be the CEO of a hospital. It might be the president of the university. How do they come about and make the decisions that are important for their institution, their country, their health system? And what it breaks down to is their close compatriots, country members, in the circle in red. The decision makers confined by, restricted to some extent, of course, by legislation, by financial responsibility, by the environment, etc. But what they do is they lean on the people who are closest to them, the people who have the quality of a top connection, who have a reputation, who have the capacity to present and develop and their research and their findings, and the quality of the connections that they have with that. And he coined a term, embeddedness, in this process. People who are embedded in the environment, close to the decision makers, have the greatest influence on how things will proceed. The diagram on the left there shows you the decision maker and the key advisors and research institutes, advisory committees. Those are the red part of it. But look at the green on the outside on this. These are academics, technical agencies, consultants, and the like. And then the blue area on the outer circle, NGOs, international organizations, academia in general. So the key things deciding about how to proceed is usually made through the influence of people who are embedded close to those decision makers. So there's a research gap for low-income countries. And I know that Kenya is a middle-income country, but I think this still applies to low and middle-income countries. Foreign countries tend to fund research for big diagnostics, treatments, and the like. They fund clinical trials. They provide equipment, buildings, and the like that can be used. And what's been neglected in this process over the past number of years is the support for investigator-initiated research support. And how you can see this is perhaps in this analysis of principal authorships. Low-income country investigators are the principal authors in less than 4% of the low-income community and health policy research publications. So the questions that are being asked and the questions that are being answered and the analysis that are being done is largely being done by well-intentioned people in another country, probably using as a motivation the experiences they've had in their own country. One Ugandan physician who we met termed it this way: we find patients and collect data for the donor country studies. Well, there's been a transition, and one of the key away from this, and one of the key milestones, I call it, on this is the Bangkok Conference, which was held in 2008, and I think it was 50 or so ministries of health, ministry of science, and the like from 50 different countries came together in Bamako, Mali, to make some recommendations on just how the direction of research should be governed and decided on. They recognize that global research for health agenda should be determined by national and regional agendas. What they wanted to control their own research health agendas. They wanted to promote evidence-informed policies, policies-informed research, and effective dissemination of the results. They wanted to assist they recognized that they needed some assistance in building community health research capacity. And of the 23 calls to action that they issued in 2008, several of them had direct relationship to health research. The priority for research and innovation should be especially on primary care, and to control their own health research agenda. They wanted to control their health research agenda, and they felt that primary health care is probably the area that needed the most attention. And they wanted to improve the capacity to implement research policies and to foster a strong research culture. They wanted to promote informed policies, policy-informed research, and effective dissemination of the results of that research. And they wanted to assist countries through collaboration to build strength, strengthen the research for the health capacity. So the challenges for of the ministries from health and the Bamako research action, timing was not the greatest. 2008 coincided with the last worldwide recession. It was a bad timing. From 2008 to 2010, there was a worldwide recession, and as you know, from 2020 until present, and probably for another year or so, the world will be struggling with how to deal with pandemic, how to deal with wars in Europe and the like. All of this is disrupting the natural economies and the natural flow of support from the well-developed countries to the lower and middle-income countries. There are internal challenges as well. The lack of capacity to do independent, what I would call investigator-initiated research. The lack of the lack of local mentors and coaches, and the lack of funds to do local investigator-initiated research funding. And the inconvenient truths that you're dealing with every day. Africa is dealing with what I understand is something like 25% of the world's health issues and problems, with only a fraction, 15% of the world's health professionals. So you're dealing with tuberculosis, with HIV, with famine, with floods, Ebola, malaria, monkeypox now, at a scale that the rest of the world is not burdened by. With fewer healthcare professionals and researchers in the mix. Well, this is another milestone, I think, in this transition. This one happened earlier than 2008. It started earlier than 2008, and it's the microfinance movement. The Nobel Prize winner Mohamed Yunus began this in Bangladesh in 1976. And from there it's blossomed out and spread worldwide, and I know in Africa. It's had its ups and downs, its bumps along the road, but essentially what it's trying to do is to provide small loans for people who've got ambition and energy, who want to start their own enterprise, provides them with opportunities, provides mentoring and coaching along the way, allows this to develop with minimal collateral, and the repayment terms are flexible on this. So in essence, what they're trying to do is to prime the pump, to create a culture of entrepreneurs, risk takers, who are prepared to go out, improve themselves, and in so doing, improve the welfare of their own country. Okay, this is a backdrop to what we call micro research. The micro part of it has nothing to do with microbiology. It has more to do with the model of microfinance, as you'll see. And the research part has primarily to do with healthcare professionals. It began in 2008, or I guess the origins of it started in 2008. On your left is Jerome Kavakayanga. I'm in the middle, a little bit younger than I am now. And the third person is Noni MacDonald, shown on the right. And what happened in 2008 is that Jerome had invited Noni and myself to come to Embeddedness, Uganda, and to do a workshop to train some of the local people on how to do investigator-initiated research. It was a 2-week workshop. It went through some of the basics on this, how to ask an appropriate question, how to decide what is an appropriate question, some presentations on qualitative methodology, quantitative methodology, statistics, community engagements, research ethics, etc., etc. And at the end of the 2 weeks, there were about 25 people who were participating in this. Noni and I were just blown away by the excitement, the energy, the enthusiasm that we saw demonstrated from the people who were participating in this. And just before we left, Jerome sort of pulled us aside. We had dinner with him. And we told him about how excited we were about the outcome from this. And Jerome said very solemnly, you know, Bob and Noni, you've done a terrible thing here. We were dumbfounded by that. And what Jerome said, well, you've opened their eyes to opportunities, and now I'm going to have to close the door on this because I don't have the resources to support research, financial resources. We don't have a cadre of people who can act as mentors and coaches to bring them up to a higher level. And so, unfortunately, this initiative, well-intended, will end with this. So Noni and I took this as a challenge. The term micro-research and the fundamentals on what it is and how we were going to achieve a final objective hadn't been decided on this, but we took this as a red flag, a challenge to us, and we been working on this since then to try to see what can be done. So one of the first things, so we could call that 2008 workshop the very first micro research workshop, but there wasn't a workshop in 2009. There were 2 workshops in 2010, and it was around this time in 2010 where we were trying to to understand the needs and to understand what it is that we and others needed to do in order to try to bring about a development of research capacity. So when we went about it, we created a questionnaire. It was a qualitative and a quantitative aspects to it. We chose 50 people we knew from East Africa. All of the questionnaires were distributed to people in East Africa. It included Kenya, Tanzania, and Uganda. And we had something like a 70% response rate. And out of that, and further discussions and further in-depth interviews formed the basis of how we solidified what we now are doing in micro research. So one of the questions, what are the 3 biggest maternal and child healthcare challenges? And there was identified health access, social determinants of health, and health services were the biggest challenges. I say maternal child health because as a pediatrician, and knowing as a pediatrician as well, this is one of our primary interests and our initial supporters, but I think we can just now generalize this to healthcare challenges. The question, what were the 3 biggest challenges to developing health research in your region and country? And how what was identified, just over 50%. Health researchers, there were very few of them, and the skill sets in order to do research, they have recognized that there was a lack of the skill set and of the number of people in order to really enhance the investment in research. And we brought sort of some reality to it. If you had $1 million for health research, how would you like to distribute it? And the answer there, again, over 50% thought that it should be distributed through community-related health research and research related to health systems in their country. If you had $100,000 to help university health faculty become involved in research, how would you distribute it? And here, 2/3, more than 2/3 of the answers were, and the youth part of the faculty, to undergraduates, to graduates and residents, and to young faculty. This is rather interesting. If you recall, when I started this questionnaire, we sent it to roughly half the people we sent it to were young investigators, and half the people were more senior investigators. And in that, we included some of the people who were institute directors, hospital department heads, that sort of thing. But there was no difference on the responses when we compared the 2 groups. All of them seem to recognize that investment should be put into the hands of the young faculty, young graduate residents. They wanted to build from the grassroots up a community and a culture relating to research. This was a question more closer to reality for us. If there was $50,000 available to support research projects, how should it be used? And no one thought it should be used as a single one grant, $50,000, where there would be a lot of applicants and only one recipient from that. A few thought it should be divided up into 2 grants of $25,000, but the vast majority, close to 90%, thought it should be small grants. The small grant goes with a high acceptance rate. So an acceptance rate where when the research was brought up to a level of research quality that it should go forward, that it should be supported. So these ideas form the basis of how we have developed micro research over the years. We want to decolonize and democratize research by placing research skills and opportunities into the hands of the people who live and work in their own community. Through their research, they'll strive to improve the health of the people in the community. And the pillars are certainly education and training, research funding, those small grants that I mentioned, a mindset to bring about change and improvements on this. We want to always create credible science, and it's reliant virtually entirely on volunteerism. Volunteerism both from here in Canada, but also largely volunteerism in the sites where we've worked primarily in East Africa. So remember that embeddedness circles that I had shown you early on. Here is another rendition of that. The expression here, we're come from the ways in Canada. The bridge that we are trying to create is a bridge to enhance the skills and capacity of the local people who are embedded in the society in East Africa, so that they will become embedded in that society and will influence and give some guidance anyway to the decision makers in the country. So micro research, through the evolution of this, we describe it as going in 3 stages here. And what I've been talking about mainly is about the workshop, the teaching research, and this is a large part of what we see as our success on this. Workshops are typically done, they were done in person until COVID hit, and we transitioned to a virtual type of workshop by and large since that time. Workshops are organized by the local institution, university or hospital, who've invited us to come and help them train and improve the skill set of people who are involved in health in their community, in their setting. So they organize it, they select who is going to be a participant in it. We want this always to be a close, interactive workshop. The number of people who can participate in this is ideally around 20 or 25. We've done a couple of workshops more than that, of 30, 35, and some with fewer than that. But in the workshop, these 25 people come together. The institutions select who's going to be participating in it, the guidelines we have is that we want a mix of health professionals involved in it, and we want, as close as they can make it, a 50% gender equity in the group. And over the years, this has easily been achieved. The participants, by and large, don't know each other to begin with. They're strangers. They work as a group, and by the end of the workshop, they're working as a team. The first day, there's some presentations and orientation, introduction about how to use the web for educational purposes. And their homework for that first day is for each of them to go home and think about, in their own work environment, a research project that would enhance and improve the health and the quality that they can predict. The next day when they come back, they're divided into teams, usually teams of 5 or 6 people. And each person on the team presents to the other members of the team their idea. And the team decides, not us, the team decides which one of those ideas is the one that they will approach as a team. And then through the rest of the 2 weeks of the workshop, the team works to develop their research idea, improve it. And this coincides with presentations which are being made about qualitative methodology, quantitative methodology, statistics, research ethics, health policy, decision-making, how to make presentations, etc., etc. That goes on for 2 weeks while they are developing, and at the end of that 2 weeks, they make a pretty polished presentation to the leaders in their community, people with distinguished research experiences from their own community. They present their work and they get some feedback on that and from us about how they might plan to go ahead. And they receive, let's call it a ticket, a ticket which allows them to continue to work as a team and to make a proposal to micro-research, a proposal to accomplish the research that they set out to do. That proposal is twice a year that they can submit this. The proposal is taken by us here in Canada. There are about 300 people in Canada researchers who volunteered to act as reviewers on this, to provide ideas, to identify changes that need to be made in order to bring it up to the quality of research that is deserving of support. This is fed back to them. They have a coach from their original workshop experience, one coach who's from Africa, and we provide a coach from Canada. The 2 coaches work with the team to bring about these changes. And when they've addressed the changes that are recommended, they're given approval on a scientific merit to proceed with their project. They then have to go to their local institution to get research ethics approval, to have whatever approval is needed from local communities, etc., and to proceed on to do with this, to do the research, and to implement the knowledge, and eventually to bring about to publish their results in a journal. I'll give you some examples of this in a minute, but the premise that we have is that local health problems need local solutions, i.e. solutions need to fit the problems and need to fit the culture and the context that's present in that community. And they want to ensure that the research findings can lead to solutions and can be applied and used in the country where the research is being done. So who's driving the bus? The people in the host country are driving the bus. Local universities are participating, hospitals, training sites are participating in this, in recruiting, providing the facilities, etc., providing co-teachers with us as we do the 2-week workshop. And based on that, a teamwork develops and perfects the research ideas that they have. So, starting in 2008, we've expanded since then from Embeddedness in southwest Uganda. 19 institutions have asked us to present workshops in 8 countries, all of East Africa, from Ethiopia, Kenya, Tanzania, Uganda, Rwanda, Malawi, have had at least 2 workshops in each of those countries, and in Kenya and Uganda we've actually had several more workshops there. A total of 47 workshops, and some pictures of the participants on graduation day, if you like, shown there. There's been over 1,200 participants in these workshops. About a third of them were doctors or dentists, close to the same number of nurses and midwives, and as you see through there, lab technologists, pharmacists, allied health, etc., have been involved in it. And the outcome of this, there have been 126 projects have been launched. 51 of those have been completed. There have been 49 publications in peer-reviewed journals. And equally important, or more important than that, it's led to policy changes in their own country and lives being saved as a result of that. Remember, the questions that are being asked by people who know the local environment and know what the potential is to make changes that will improve the health. I'll give you some examples here of 2 of the early teams that came about. Isha Grant, shown on the top right, a picture of her. Her idea, her question was to address, why is it babies who die in the first week of life in rural communities in Uganda? When she told us about this question, we said, well, the World Health knows the answer to that. And she pointed out to us that that's not the case. And the World Health collects largely data from big institutions, hospitals, and the like. So they have little access to information that's from the small rural communities, where at the time in Uganda, more than 2/3 of the births are done in rural communities. So how did she do it? She gained the trust of the local community, the village elders. She spoke the language, she knew the culture of the people, and she gathered together a dozen or so courageous women at a time. I think there were about 40, close to 50 women and a few men who told the story about how their baby, what their circumstances were that led to the death of their baby in the first week or so of life. Interesting in that she used an established World Health format for that. It's called a verbal autopsy, oral autopsy. And she actually perfected better questions to ask in this rural environment. And since then, the World Health Organization has adopted the suggestions or recommendations into their policy, into their format on this. But the surprising thing for us was that about close to half, about 42% or so, of the babies who died, it could be identified that they died because of sepsis, which was related to originating in their umbilical cord. This was a decision come to by a group of pediatricians who reviewed each of the documents, each of the oral autopsy documents. 50% of the deaths in this environment were due to sepsis, originally from the umbilical cord. So another study was done by Florence in southwest Uganda, a different part of Uganda than Isha had been working in. She was an anthropologist, and her question was to try to document what the traditional practices were around pregnancy and birth in southwest Uganda. And she analyzed it from the point of view, what are practices that are beneficial for the mother and the infant? What are practices that are neutral, have no real bearing on it? And what are practices that could be detrimental to the health of the mother or the baby? One of the observations she made is that in rural Uganda, the tradition is to apply different things to the umbilical stump shortly after birth, including soot and dirt. The idea is to try to dry the umbilical stump up in order to have it fall off. The two ladies presented their results at a conference that we had organized, micro-research conference. We called it a micro-research forum. And all of a sudden, the lights went on in both of them. Aha. We now had a good idea of what the potential source of the infection might be for the umbilical sepsis that resulted on that. They took and both of them published their results in a peer-reviewed journal. They took their results to the Ministry of Health, presented their findings, and the Ministry of Health, this is in Uganda, wanted to validate, verify this. They wanted to know if changes could be made that would be accepted in the community and would be followed by the community. And that the solution was to apply a disinfectant, chlorhexidine, to the umbilical stump immediately after birth. And this would not interfere with the cultural practices because essentially if chlorhexidine was applied initially, then a very low likelihood that an infection would result. In Uganda, a cottage industry then came about for producing small packages of Umbigel, chlorhexidine tubes, and these are distributed in all of the mama kits that are distributed in Uganda, and I think some in Kenya and Tanzania as well. So a cottage industry has been created. Umbigel is now being used in rural communities where births are occurring. And in another study that was done in a different part of Uganda, just recently, about a year ago, they published their results, and neonatal deaths relating to sepsis was now about 7%, a decrease of 35% with this one small thing, which is creating an industry, saving lives in Uganda and elsewhere. Well, there have been 50 or so projects completed that are like this. Not all of them are as dramatic, but all of them were the ideas and the questions that were created. The investigators in the local site had done this. We did a follow-up study. We're doing follow-up studies, and we questioned the people who had participated in workshops for us over the time. As I said, about 1,200 people have participated in one of the results that comes from that. We're hoping to create networks. Networking now, as we're seeing through Zoom and other web-based networking, are a lot easier than they were in the past. And so people with a common interest can join together no matter where in the world that they are. So we're encouraging that those networking within microresearch and outside of research, microresearch, to get involved, to communicate and contact, to share ideas and develop new ideas with people from around the world. Microresearch has had many helpers, volunteers over the time. Some in Canada, universities, an organization called Academics Without Borders, the Rotary Clubs, our own institution, our own universities. But even more important are the institutions in Africa and elsewhere that have worked with us. As you know, Mbarara University, Makerere University in Uganda, University of Nairobi, Gertrude Hospital, other institutions in Kenya, Tanzania, Rwanda, and listed at the bottom of the page are several of the journals where publications from have been made from people who've done their research with the micro-research model. Okay, this is the end of my presentation. I'll be happy to answer questions now, or if you have questions later on, I'll turn it back to you to lead the way and with questions, comments.
Okay, thank you so much, Professor Robert, for that very enlightening discussion and presentation on micro-research. And I know most of us are enlightened what micro-research is all about. And for the ones who are around, anyone who has a question or a clarification, this is your chance. You're only going to take 2 minutes because you have another online speaker.
Thank you very much, Dr. Mary Joy. Are you able to hear me?
Yes, I can hear you.
Thank you, Bob. This is Professor Biambo. We met, I think, when you were there in University of Lossey. Professor Biambo is the Vice Chancellor, Meru University of Science and Technology. 2 points. Number one, really to appreciate you together with your friends, Professor Nuni and the other one in Uganda, for really living up to your words. You said you will participate and you are participating. I know it's very early in Canada, and for a senior citizen and a young person like you to wake up in the morning takes commitment. Thank you very much. Number two, you are able to hear me?
Yes, yes.
Micro research, the way I understand it, the way you have explained, is doing research at a local level, and therefore it engages quite a number of people, again, in terms of students really to engage in, as your people also work in those medical related fields. Just something for a thought, but thank you very much. I'm very happy that you agreed to participate in this conference. Thank you.
Yeah, well, thanks very much. As I mentioned, some of we try to present in a nutshell. We cannot go in depth into statistics, qualitative, quantitative methodology, but we introduce the topic, and together the team decides on the question, and the question might relate to what sort of methods you're going to use to follow through on that, and they help them along that road to improve on that. So it turns out that the types of questions that they're asking, maybe about 2/3 of them are best addressed on a qualitative type of method on that. So qualitatively, just, what are the feelings, the senses, what is the motivation behind that causes things to go on in a certain direction. And you're quite right, because these are small projects, local setting, the use of statistics is probably not as vital. But several of them will go and they'll be using, analyzing either regional or national statistics and national databases where statistical methods can be used on that. So whatever question they have sort of gives an idea on what the methodology will be. And what we hope and we try to do is to ensure that the best quality comes out of that. And I know that when we're in Kenya or other countries, we lean heavily on people like you to help us when the presentation is made about statistics or quantitative methodology, so that you present this and explain the issues on that, and the coaches, of course, for each team of 5 or 6 people, the coach is a local coach as well. So we lean heavily on the resources that can be provided there. So thank you. I hope I've answered that question.
Very well, very well. Thank you very much, sir.
Thank you, Prof. We go to Dr. Mariga.
Yeah. Thank you so much, Prof, for the well-presented work. And I have a comment and a question at the same time. Firstly, it's so unfortunate that in our continent we have such high mortality rates at this era. And I would like, of the 51 completed projects that we talked about, how many are self-sustaining? Because we know in this area or in our continent the problem is with sustainability and the link between the innovators and the consumers of the innovation. That is between the higher institutions of learning, the various researchers, and the people who those innovations that come out of those works are meant for. So I would like to know whether there was any link, because that's what has been the failure of many projects in the developing country. Thank you, Professor.
I have to apologize. There's quite a bit of echoing on my end of it, and I don't think I took in all of the comments that you were making. It was an echo effect that made it difficult. Perhaps someone can, or you can repeat that in a brief fashion.
Yeah, sorry about that, Professor. Can you hear me correctly now?
I can hear you. There's still some echoing there, but if you can say it in a nutshell and slowly.
In a nutshell, I was trying to, firstly, thank you for the presentation, and then I was asking, of the 51 completed projects, how many are sustainable, that is self-sustaining? Because in these in developing countries, the failure in the uptake of these projects is sustainability, and secondly, the link between the innovators and the consumers of the innovation, that is the industry or the higher institutions of learning, and the consumers of the new ideas that come up out of these researches. So is there a link? And secondly, is there sustainability of the projects? Thank you, Prof.
Okay, I think I understood that better now. So the question, main part of the question was about sustainability of the research that is undertaken. And that is one of the reasons why I think that the fact that the question is generated by a local site, that they have coaches from the local site who are probably addressing that aspect to it. And that during the review process, that's specifically one of the questions that we ask of the reviewers. And when I say we have reviewers, we have always at least one reviewer from Africa and one reviewer from Canada. Usually we have about 3 reviewers on that. And that's one of the questions that they're asked to address. Is this something that can be achieved, and will the results make a difference, and can they be sustainable? And I think I can speak with confidence that there is built into this whole process sort of restrictions that would try to ensure that the sustainability is one of the things that's being achieved. I can give you another example. I think this one was from a researcher in Tanzania. And the person who proposed it to her group was was a physiotherapist, I think. And she was dealing with children who had club feet. And she pointed out that one of the primary tools in trying to correct a club foot was using a brace, and the brace was only manufactured out of the West, I think from the United States. It cost $300. It was very effective, but very few people could afford this $300 brace. And so what she proposed was to use a brace that was going to be made locally, similar in design and the like from the brace that was available. But it would only cost about $30. So she tested this on that. So they created something, a method of management of club foot, which is now sustainable and developing, self-initiated and self-propagated on that. I hope that's a good example towards your sustainability question, which is really comes at the heart and is really an important. Okay, over.
Thank you, Prof. One more question. Anyone with a question or a clarification?
Yes.
Okay. Good afternoon, Dr. Bortolucci. My name is Charity Ichuki. I work for the university here as a Deputy Vice Chancellor. I'm interested in this micro grants. I have seen your research and your data that majority of the respondents would have liked a 2K grant, $2K. I'm just wondering, have you managed to do that? How much of research can you get out of 2K? Does it work in the whole thing?
Okay, thank you. And in fact, it's 2,000. It was originally 2,000 Canadian dollars, which are not quite as strong as the American dollar. And in fact, because of financial problems, we've had to lower that to $1,500 Canadian dollars. We did that a few years ago in consultation with our advisory committee, which is made up mainly of people from Africa. And we posted them, we're having financial problems with support. We could carry on at $2,000, but it would mean that we're not going to be able to accept as many proposals. Or if we lowered it to $1,500, we would still be able to accept and fund the vast majority of the projects that come through. And the advice that we received was, even if it's lower amount, $1,500, it's worth doing that route rather than restricting the support. And when I say it's $1,500, it's $1,500 worth of materials, equipment, other things than that. And there's probably well more than that, which is contributed in terms of in-kind resources, borrowing some equipment to be used for it. So if one wanted to tabulate the actual cost of the research, it would probably come to several-fold more than that. And then these are small pilot projects, by and large, and several of the groups have completed their pilot project and then moved on and used this as the basic data to make a proposal to a larger organization for a much larger proposal. Or even at the time that they're doing it, found support from another organization which is willing to invest funds into it because they've got the assurances that there's scientific rigor behind it, by virtue of the fact of the reviews and the support that's been held on that. So when we say $1,500 is what we managed to come up with out of our pocket to support it. But the actual activity is probably several-fold more than that because of the in-kind contributions and the contributions that they've been able to garner from other sources.
Thank you very much. I'm just so impressed that that amount would get you some results. I'm impressed.
But Bob, through the moderator, can I add something? This is Professor Biambo again from Meru University. I think the micro research addresses local issues. This can be a home with small homes, a village with small homes, just few homes. But very important, the second objective, especially in an African context, is basically for young researchers who still need to work with some people and be mentored into serious research later on, be it grant application for bigger one, but you have to start somewhere. And that's why I think to me it's very, very important really for our academia who are still young in the field, and even our students, masters and PhDs, who want just to be mentored. Remember, in this arrangement, there are mentors all over who now work with them and they train them on how they can procure some of this small grant and then later on see how to blow it up once they know how to handle the ropes that there is. And to me, that is one of the very fundamental issues that this kind of research addresses. Thank you very much.
Yeah. No, I think exactly. I think you've said that very, very well. The motivation and what our objectives are. Thank you for the comments.
Thank you. Thank you.
Very joy, we have lost you.
Oh, I was saying we have one more question. We have one question from our and then we wrap it up so that we can allow another group to have their guest speaker.
Thank you, Dr. Mirinjoy. Professor Botolusi. Okay. First and foremost, may I thank you for that informative presentation. My question is on the choosing of the problem in the community. From what you have talked, it's like we need to have proper community entry processes, which will also need to have participatory methodologies for us to be successful. The training you talked about, does it also include community entry processes while trying to identify the problem?
If you are comfortable, you are not also making.
Over to you. Professor Robert, over to you. Did you get the question or we can repeat?
Oh, okay, again, there was a bit of an audio problem, but I think it was just how communities become involved and how do we encourage this and how do we ensure that we're meeting some of the needs of the community. I think we're quite aware of the issues and the problems with that, especially since our culture is so different from that. One of the presentations during that 2-week workshop is specifically on that community engagement. And what we do with that is, this is done in the early part of the second week of the workshop. So we know by that point just what the projects are of the teams. Usually there's 4 or 5 teams. And we use those as examples on that. Who are the communities that you are going to be dealing with? How are you going to engage them in the process and gain their collaboration and their cooperation with that? We're always joined by a person from the local institution who understands, of course, the culture and the environment and who has some expertise on community engagement for that. And it's a set presentation both to make people who are aware of this, but how important it is to have community engagement. You just cannot assume that that's going to occur. And as well, ensuring that there are the local experts who are there who can guide them and coach them along that way. I'm not sure whether I heard everything that you had said, but I hope this at least partially addresses what the question was.
Thank you. That was very well responded to. I take this time to really thank you, Professor Robert, for taking your time to be with us this afternoon. I know it's very early in Canada, and we look forward to having more conversations and more engagement with the micro research team on your side and the Meru University team. Thank you so much for your time. Thank you for inviting me.
I look forward to joining you at some point in the future.
Okay, thank you. Thank you, team, for being with us up to this time. We take a health break and then we come back at exactly 3 p.m. so that we can be able to close in with the other 5 presentations. For the presenters that we had in the morning, thank you so much. And we look forward to seeing you back at 3 p.m. Thank you so much and enjoy your health break.